you for the introduction, Dr. Freed. Okay, so the title of my talk is High INR is a Contraindication to Paras and Thoras. And so to start things off, so the risk of bleeding complications when you're undergoing an open surgical procedures is considered to be pretty low because the surgical field can be visualized, and so if the patient does actually bleed, then the surgeon can apply surgical hemostasis and kind of, fix the problem temporarily or not. In comparison, in closed invasive procedures such as thoras and paras, the person doing the procedure tends to not have as much control, and so bleeding can't be directly controlled. And so in particular, there has been hesitation in performing these procedures, in particular when there is an increased bleeding risk. So if the patient has an elevated INR, if they have low platelets, or if they are on anticoagulant or antiplatelet therapy. Previously, there were different medical societies that actually contraindicated or strongly recommended against doing these procedures in patients who were coagulopathic. Several decades ago, the American Thoracic Society stated that coagulopathy in patients undergoing thoras was associated with an increased risk of hemorrhagic complications, but they didn't actually define any parameters for the coagulopathy. In 1985, the American College of Physicians said that there was actually the major contraindication to doing a thora was any type of clotting abnormality. In particular, they stressed on having low platelets of less than 50, but there weren't any parameters for paras. And so we know that elevated INR, thrombocytopenia, platelet or renal failure causing uremia and platelet dysfunction, both qualitatively and quantitatively, can increase your bleeding risk. And oftentimes medications are held and blood transfusions are given to correct these levels. But the question I'm trying to answer is whether or not this is really necessary. I mean, giving blood products is not without risk, and as of 2013, it was the most common procedure that was done in the hospital. So just to kind of give you an idea about some of the parameters that, for example, the IR guys at our hospital are using before they're doing these procedures are, so for a paracentesis, they want their INR to be less than 3 with platelets greater than 25,000. If the patient's on warfarin, they go for an INR of less than 2, whereas for thoracentesis, it's also less than 2 and platelets greater than 25. So the first study that I'd like to talk about today is kind of one that paved the way and moved guidelines to becoming a little bit more or a little bit less strict on parameters before these patients are undergoing these procedures. So it's called Lack of Increased Bleeding After Paracentesis and Thoras in Patients with Mild Coagulation Abnormalities. And so this study was published in the Journal of Transfusion back in 1991. And it was by McVeigh and Toy, and the purpose was to determine whether a mild coagulopathy not treated with blood products before the procedure was associated with an increased risk of bleeding after the paras and the thoras. And so how did they define mild coagulopathy? So this is important because we're actually going to come back to it again in a later slide, but they defined it as a PT or PTT that was from the upper limit of normal to about 1.5 times the midpoint of normal. And so the midpoint of normal, they basically are multiplying that 1.5 times. That's not related to the INR. The INR is about 2.2. The platelet count is anywhere from 50 to 99. So that's for a mild coagulopathy. And then for a moderate coagulopathy, the PT or PTT was 1.5 to 2 times the midpoint of normal. And so that equated to an INR of about 3.8, which is fairly high. They also looked at serum creatinine because we know that uremia can be associated with platelet dysfunction. So all the patients in the trial had to have their hemoglobins checked within 48 hours before the procedure and then afterwards as well. About 16% had undergone ultrasound use with the procedure. And initially there were 2,038 fluids that were submitted, but many of them were excluded because the patients either didn't have the appropriate labs pre or post procedure, they had active bleeding for reasons unrelated to the procedure, or that it wasn't it wasn't a thora or para, but it was peritoneal dialysis fluid or tube drainage. And so finally they ended up with 441 peritoneal and 224 pleural fluids. The needle-borne length were not always recorded, but for the most part, they were using 20 or 22 gauge needles. And so what they found is that in patients who did not receive any FFP before the procedure, that there was no significant difference between their hemoglobins pre and post procedure. And so that's in patients both with normal PT and PTT or those with prolonged, equating to an INR in this study anywhere from 2.2 to 3.8. The same thing held true with low platelets. The only test that actually, the lab abnormality that was associated with significant blood loss was an elevated creatinine. But those lab levels were greater than or equal to creatinine of 6. And so overall, the frequency of patients with a hemoglobin decrease of greater than or equal to 2 was about 19 out of 608 patients. And there was one patient that required a transfusion. He had alcoholic cirrhosis. His renal function was normal, and his PT was about 1.3 times the upper limit of until 1.3 times mid-normal. And so he was the only one who actually required a blood transfusion. But so, as I mentioned before, the lab abnormality associated with significant bleeding was the creatinine, but it had to be a significant, like greater than or equal to 6. Overall, they found that even with the elevated creatinine in those undergoing the procedure, their morbidity was low, and so they still don't recommend giving blood products prophylactically prior to doing the procedures, but to kind of more closely observe these patients after they undergo the procedures. So interestingly, after about 20 years after this study was done, in 2010, the British Thoracic Society made some changes to their guidelines, and so previously, they had said that non-urgent pleural aspirations, and this right here is directly from their website. So they're saying that non-urgent pleural aspirations and chest drain insertions should be avoided in anticoagulated patients until the INR is less than 1.5. So based on the McVeigh and Toy study, primarily based on it, they changed their grade level to a C, which for whatever that's worth, it's basically saying that they have 2+ evidence and that their evidence is based on case control or cohort studies in comparison to a better grade level, which would be based on systematic reviews. But the thing is that in quoting this McVeigh and Toy study, they actually don't have the parameters correctly documented. So they're saying here that patients known to be receiving anticoagulants or in whom there is a suspected coagulopathy, such as liver failure, they should have their PT or INR measured before these procedures. McVeigh and Associates retrospectively reviewed 608 cases undergoing pairs or pleural aspirations, and they found that mild coagulopathy, defined as an INR less than 1.5, or the low platelets, did not adversely affect the risk of bleeding. But this is also directly from their study, and they're not saying that the INR is less than 1.5. They're saying that the PT or PTT is the upper limit of normal to 1.5 times the midpoint of normal range, and that equates to an INR of 2.2. And so that's for the mild coagulopathy group, or up to 3.8 in the moderate group. And so unfortunately, based on these recommendations that were published in their guidelines, a lot of studies that were done that were influenced by the McVeigh and Toy also quote that. So moving on to another one. This was a study that was also influenced by that initial one. It was published in 2013. This one is called The Safety of Thoras in Patients Who Underwent the Safety of Thoracentesis in Patients with Uncorrected Bleeding Risk. So this one was a prospective study. It enrolled 312 patients. And so they were also checking hemoglobin levels before and after the procedure. They were also evaluating for post-procedural hemothorax. They used slightly larger needles, so they were using between 14 to 15 gauge needles. And so the thing that I liked about this study is that it was evaluating patients who had multiple risk factors for bleeding. So out of their 312 patients, they had 130 who had an increased bleeding risk. And so 95 had just one bleeding risk factor, 31 of them had 2 risk factors, and there were 4 that had 3 risk factors. And among those were an INR of greater than 1.5, and they clumped liver disease and warfarin in the same group, platelets less than 50 and a creatinine greater than 1.5, and whether or not they were on anticoagulation. Despite some of the patients having more than one risk factor, they still did not find a significant difference in the hemoglobin before and after the procedure. And no one developed a hemothorax as a result of thoracentesis. And so, as I mentioned, the reason that I really like this study is because I felt like it highlighted the safety of thoras in those who have more than one bleeding risk factor. So moving on to paracentesis. So this study was called Paracentesis of Acidic Fluid, and it's done by a gastroenterologist who may still be practicing down in Los Angeles, Bruce Runyon. He published this in 1986 because he was not happy with the reluctance of physicians in performing these paras, and he felt like at that time it had partly to do with the fact that they were using larger caliber needles. And so his only focus was not on coagulopathy, but in general to also say that paras in general in terms of infection are safe procedures to do. And so he included 229 paras that were done in 125 different patients. And the cause of the ascites could have ranged from liver disease from alcohol, it could have been from intra-abdominal carcinoma, cardiac failure, or other causes as well. The majority of his paracenteses included in the study were diagnostic, so only about 60 cc's were removed. When recorded in the procedure notes, the majority of the procedures had to use 22 gauge needles. The PT ranged anywhere from 0 to 18 seconds, and the platelets were from 54 to 1.1 thousand for the range of the platelets. And so having a coagulopathy didn't preclude patients from undergoing the paras, and they were not even routinely measured for everyone. So in terms of complications, he had one transfusing requiring hemorrhage in a single patient who underwent 2 paracenteses. They were done 9 days apart. They both resulted in abdominal wall hematomas, but there was no intraperitoneal hemorrhage. The first time the para was done in this patient, his prothrombin time was 9 seconds, and then before the second one, the prothrombin time was 6 seconds, so not significantly elevated. The patient had a lot of things going on though. So he had the significant liver failure. He also had renal failure with a creatinine of greater than 2.3 even before his first paracentesis was done. And he developed a variceal hemorrhage and required 6 units of blood and ultimately passed away, but they didn't feel like the paracentesis was related to his death. Other complications included other hematomas. There were 2 of them that didn't require blood transfusions. There was 16 different cases where there were blood-tinged acidic fluid. Again, no transfusions were required. And so ultimately what he said in terms of coagulopathy is that there wasn't significant differences in those patients who, for example, developed bloody ascites or hematomas in comparison to those whose paracenteses did not. And no fatalities resulted from the paracentesis if you don't count the one patient who passed away from his liver and renal failure. So, so this study here, well, not a study, but this is kind of a summary of some of the different studies that have been done on patients who have undergone thoracenteses who have high risk for bleeding. So we already talked about the McVeigh and Toy, and we talked about the Pachalski study as well. So this, I'll just briefly kind of go through because I know there's multiple studies that are listed here, but for this Patel and Joshi study that was published back in 2011, so they looked at patients who had both an abnormal INR and they had thrombocytopenia as well. Their patient population actually had pretty significant coagulopathy. So they had about 17% of their patients that had an INR greater than 2, and 7% that had an INR greater than 2.5, 4% that had an INR greater than 3. Their platelets were quite low as well. So they said that despite their patients not having any of their coagulopathy corrected, they still didn't see procedural related bleeding before and after the procedure was done. And so they felt that there shouldn't be thresholds for coagulopathy before these procedures are done. They felt like that threshold should be eliminated altogether. The other one that was a pretty significant study is the one that's commented down here. Down here. It's by Alt and colleagues. It's actually a 12-year prospective study that was published in 2015. This one was done on inpatients at Cedars-Sinai Medical Center. And so the purpose of that study essentially was to evaluate for complications of thoracenteses, and they were basically watched for up to 24 hours after the procedure was done. And the types of things that they looked for after the procedure were re-expansion pulmonary edema, iatrogenic pneumothoraces, hemothorax, splenic lacerations, vasovagal reactions, bleeding at the site of the procedure, and we already mentioned hemothorax. So they had 9,320 thoracenteses that were done in 4,600 different patients. They did not give anybody blood products prior to the procedure being done. They had about 25% of their 9,000 patients who had an INR that was greater than 1.5, and about 4.5% had platelets that were less than 50,000. So they really had quite a range of the coagulopathy before the procedures were being done. And so they had no significant associations that they found between patients who had abnormal coags and low platelets in comparison to bleeding complications. And so they felt like a lot of the medical societies that were giving these guidelines about being extra cautious are not entirely warranted. They actually quoted the British Thoracic Society's kind of more strict coagulation guidelines as well. And so this is from their study, their 12-year prospective study. And so just to give you kind of an idea about the more strict guidelines, or the more strict, to give you an idea of the patients with the higher INR and how they didn't really have significant complications. So there's an INR of greater than 3.1, and there were 300 patients who had an INR that was that high. Out of those, only about 5 of them ended up with a procedure. And so this could have been any type of procedure. It didn't necessarily have to be related to bleeding. And one of those 5 we do know was a pneumothorax. Same thing with the platelet count. They had 53 patients that had platelets as low as less than 20, and there were no procedural complications that were associated with that. And so again, they felt like there was no significant association between bleeding and then the patient's INR, PTT, or platelet counts. So finally, just to kind of sum up everything we've talked about in the last 20 or so minutes, there have been several studies in the last few decades that have suggested that these abnormal pre-procedure INR and platelet counts don't significantly result in bleeding complications when patients are undergoing these closed invasive procedures such as paras and thoras. More than one study, however, has suggested that platelet dysfunction from renal failure can lead to significant hemoglobin drops. And so when you're doing these procedures in these types of patients, you should consider, closer post-procedural observation and whether or not the patient needs to be dialyzed or needs to be treated with DDAVP. Complications from receiving transfusions can be greater than the benefit of correcting the coagulopathy, and from the previously discussed studies, it may be time to consider reevaluating the need to correct the INR thrombocytopenia prior to these procedures being done.
Great job. Okay, any questions or comments from anyone? Daryl?
Do you recommend any threshold for coagulopathy?
I kind of agree with the studies that said that they don't necessarily even need to be checked. I think that we had some studies that were showing that INRs greater than 3.1 still weren't showing any complications. So my thought is that they don't necessarily need to be checked at all, but I know that the interventional radiologist probably wouldn't agree with that at this time.
I'm not sure if you went over it or not, but did you end up seeing any difference between Thora and Paras?
So that's a good question. There was a lot more data on Thoras than there were on Paras, and so ultimately both of them proved to be pretty safe, but it's just that the data on paracentesis is more limited in comparison to the abundance of data there is for thoracenteses.
So, did they look at the experience of the operator for doing the paracentesis? Because, like, you know, Bruce Runyon's doing all the paracentesis. He's probably done tens of thousands.
Right. And
First-year resident.
right. So basically, in the larger prospective studies, they're saying that like for example, the Cedars study, there was one operator that was either observing or like supervising another resident doing it versus doing it himself. So it was either them doing it themselves, who was a well-trained operator, versus they were supervising a less trained resident, for example, as well. So it was both. And that was also the case with Bruce Runyon in the paracentesis study. He also commented that it was not just him. There were other people that were doing it in his study, but also that they were supervising as well.
So, is it a myth? Elevated INR is a contraindication to performing thoracentesis and paracentesis. How many people think this is true? It's confirmed. How many think that it's plausible after looking at the evidence? Now, how many think this is busted? All right. Looks like it's pretty much overwhelming, and we'll close January's Mythbuster 2018.